Tēnā koutou katoa. Welcome to the inaugural New Zealand Telehealth Leadership Group webinar. It's wonderful to see you all out there. Ko Ruth Lard Tēnei. I am the chair of the New Zealand Telehealth Leadership Group, which has been around for a while. We're supported to the ministry and we provide advice to the ministry about telehealth. So we've been pretty busy lately, and you'll find us on www.telehealth.org.nz. Now, we've got a great speaker lineup for you tonight for our introductory webinar for telehealth. Now, during the webinar, we're going to use two really important terms. Number one is telehealth. And, you know, just as the telescope extends our vision and a telecucumber extends our culinary yumminess, telehealth extends the way we deliver healthcare. So when I think of telehealth as being the provision of healthcare where the provider and the receiver are at different physical locations. And it's actually been around for a while. We've had teleradiology, teledermatology, which is image storage and forward for a while. And we've also, of course, had telehealth helplines such as Plunket, celebrated its 25th birthday just last year. So it's not new, but the way we're doing it now is new. So the volume in particular and what our expectations of clinicians and patients is quite different. So the second term we're going to use is in-person. And in-person is when we're in close physical contact, in the same room. So telehealth, clinician, provider separate, in-person, together, same room. We're going to try to avoid those terms virtual and face-to-face because those terms can be a bit confusing. We're not entirely sure what they mean yet. And so now, without further ado, I'm going to introduce our panelists. In fact, no, I'm not. I'm going to let them introduce themselves. And we're going to start with alphabetical order with surnames. So Janine, you're up first.
Kia ora everyone, I'm Janine Mycroft. I'm a GP based in Auckland and also work at ProCare, and I'm the Executive Director for Health Navigator Charitable Trust. Well, hopefully you've seen the website, Health Navigator New Zealand. So the thing that I'm really excited about telehealth is one, the fact that we've just made such enormous changes in the last few weeks and really want to see these changes being embedded going forward. The thing I really enjoy is seeing people in their own environment. You get this little peek into seeing them in their home or in their office or whatever. And it's also that eyeball test. We all know that clinical judgment is so important, and being able to see the mum with the child in her arms or playing happily by her, it gives me a lot more information than just talking to the mum over the phone. So that's sort of just one example where I've found that makes such a difference, actually using video consultations to see someone. I'm not sure about you or in your practice, but for a lot of practices, people have jumped to the telephone consults, and obviously that's a really easy, straightforward. We're much more comfortable doing that. But I really want to encourage you all to give the video consultations a go, because it really does add so much more value and connection. I find it much more connecting with the person that I'm talking with, and also there's lots of studies and evidence confirming that that connection is stronger with those video consultations. So that's my first plug.
Hi, I'm George. I'm an occupational therapist by trade. I'm currently chair of the National Allied Health Informatics Group and chair of the HINS board. I also have an interest in data and standards, and I am currently a member of the Health Information Standards Group with the Ministry. My focus, I think, today really is very much around championing the concept that having made this move is really exploring the patient reported and patient experience outcome measures. I cannot wait for the evaluations to happen effectively. And I think I'm really excited to look at those evaluations and then look at ways, as Janine says, for embedding this in greater depth.
Excellent, thank you. I've just been having a little text conversation there with John Bonning, who's managed to join us now. Well done, John.
I think I'm on. Sorry, my computer is end of life. It's been overheated and overused in the last 6 weeks and is just about dead.
Well, that gives us a great opportunity to introduce yourself. So go for it, John. We'll put you on the spot.
Kia ora tātou katoa, everyone. John Bonning, President of the Australasian College for Emergency Medicine, Chair of the Council of Medical Colleges, very good friend of Ruth, who keeps me in line most of the time, and I know a handful of you, welcome everyone. Great to talk about this new world that we're about to enter, or have entered.
Anga mihi nui kia koutou, and whakalawhalahi atu to everybody that's here. It's a privilege to share spaces with everyone tonight. I'm an RN. I work for Moana Research as the Innovations Lead, and I'm also a PhD candidate at the University of Auckland, and my topic is focused on digital health equity. And I'm currently looking at a case study amongst Niue women and cardiovascular disease. And what I bring tonight is a consumer lens as well as a Pasifika lens, because we know that of the groups that that are disadvantaged when accessing telehealth are our Pasifika, Māori, and our other vulnerable communities. So it's again privileged to be here tonight and to share my lens in complementing everybody else's experiences.
Hi, my name's Sam King, and my background is general practice. I've done most of my clinical work in South Auckland, and I'm now full-time with MPS as a medical advisor. I'm also involved in faculty presenting workshops and webinars and presentations around the country. I'm very privileged to be with this group. I feel relatively underqualified listening to what everyone does. What I bring tonight is really the medico-legal aspect, and we've obviously had a lot of members calling us around, is it safe? What can I do to keep myself safe? What are the risks? And there's a lot of anxiety, I think, among certain groups of our members around how do we do this safely? And that's not just in general practice, but also with our DHB colleagues as well. I think the issues are slightly different, but certainly in both areas there are concerns. And hopefully tonight I'll be able to allay some of your fears around telehealth. I actually think it's a really positive way forward. I think it's going to change the face of medicine forever in a good way. It's going to give us all options that we didn't have before, and it's going to give our patients options, and we will be able to reach those in remote places more easily. And I think as we get used to the platforms that we're using as clinicians, it will become second nature. So I think a lot of the anxieties that we have will in fact settle down, or the anxieties that some people have will in fact settle down. And some of my colleagues in my peer review group have just taken to it very easily. I guess partly that's an age issue, that if you're born before a certain date, you're probably finding it a little bit more difficult to get on board, but you will, and I think that we all will. And it'll be really good for the face of medicine in New Zealand.
Kia ora everyone. I'm Samantha Mitten. I'm President of the College of GPs, and part of my brief for being here is probably because I instigated a lot of change in general practice, but also I've been using a bit of telephone consultation rather than video. We're doing a little bit of video, and certainly video for the mental health patients has been a huge benefit for them when they've been isolated and feeling alone. So I find that the video consultation works well, but more have been using the phone and then using in-person consultations in the afternoon. So just the experience of how you make it work for you and your practice is important, and I think it works differently for everyone around the country, and we need to recognise that, but also think about how we do it safely. Yeah.
Excellent, thanks. And that's a really great segue, because I'm just keeping an eye on the questions here, and there's a lot of discussion about safety, both for patients, culturally, as well as physically, and also about keeping ourselves safe as practitioners. So why don't we start with the patient safety aspects. Amiel, what are your feelings about particularly cultural safety via video?
Yeah, and I'm looking at the questions, and I think what's really important is what access is available for our consumers, because we've got these platforms available for our health professionals as well as our health systems, but how do we get our consumers on board in a way that allows them to access this? And we have to first look at what skills do they actually have to be able to navigate these new systems. And the first point is, do they actually know how to turn on a mobile, do they have access to a mobile phone, and do they know how to use a mobile phone? Because once they start developing the necessary skills to be able to utilize or to use a mobile phone or smartphone or computer, then they can slowly build up the skills that's needed to then navigate these telehealth platforms. And that does require skills and training. And I see that some of the questions are around the skills of what digital skills are going to be put in place for consumers. And I'm also thinking about our health professionals who may not be comfortable navigating these platforms. So I think the first point is, what access do people have, and then what skills is going to be put in place for both health professionals and consumers to then be able to navigate these new systems.
Yeah, I think those are really good points. And the telehealth website, as you know, does have patient and provider information, but it's getting it out there as well. Janine, I'll be interested in your take. You've got a lot of experience with putting out widespread information for patients.
It's really important that we focus on what's best for the consumer and improving that accessibility, but looking at ways that we can perhaps tap into whānau to help people with learning how to use devices and be able to access that technology. I don't think we've really done that in this last few weeks. I think it's really been so much on the hop that it's just been happening. Consumers want to be informed. They want good information. They want to know what to do, how to manage well at home. And telehealth actually makes that easier, because you can quickly and easily send them links to trusted informational resources. They can use the portal to access to perhaps ask a question later. Another thing that we haven't talked about yet is the huge value of open notes. It really starts to put people on a more even platform. They can see the results, they can actually see the comments you made, the safety netting advice you might have given, and they can share that with their whānau as well. So really do consider switching on open notes. We did it about 3 years ago at our practice, and we didn't notice any difference at our end. It didn't really have any impact on us, but got lots of really positive feedback from patients and clients about the advantage of being able to see that information. They felt more included. They felt more, they could review the advice. It reminded them what we discussed and what the follow-up was. So it really makes a big difference. And of course, the studies and evidence is really positive about the huge difference that it does make using open notes. So that's just something else to think about as we go on this telehealth journey.
Excellent, thank you. I wonder whether we've got any other comments in regard to patient safety. Becky, have you got anything to add there from an allied health perspective?
Yeah, there's been a lot of discussion around patient safety, certainly in terms of enabling our patients to be fully informed about what the construct means, about agreeing a terms of contract with a patient. We've talked, and I think we're making assumptions here. I think we've got to probably recognise that a lot of the patients we already have a relationship with, so we're already seeing them, or we've already had contact with them, and we're also going to segue into new contacts with patients over telecommunication modes, and I think and telehealth modes. So I think it's really important to acknowledge, as there's been a lot of conversation in allied health, the fact that we need to ensure that we are not diving straight in, that we are having preparatory conversations. You know, there's been quite a bit of discussion in a number of professional communities within allied health about making that initial phone conversation to have a discussion about what it is, what it means, about establishing a process around that. Now, we have the advantage of that because we are then potentially and subsequently going to have contact with that patient rather than it being a one-off. But it does give us the capacity and the capability to then explore patient safety, to negotiate what it means to them, how are they going to conduct themselves at home, or which environment do they want to receive this contact in? How do they want to present themselves? Who do they want present? How is that going to be managed? And that's all around ensuring that this person's needs are met from their perspective and in a safe and culturally relevant way.
Excellent, thanks very much for that, Becky. We're getting lots of really fantastic questions about equity. I think you know, we've already recognised that this is a topic in and of itself, and we could spend hours discussing it. It's really important. So that's going to come up in one of our upcoming webinars. So I think what we'll do is we'll park that one just for now and move on to clinician safety. We're getting quite a few questions there about prescribing and the Medical Council New Zealand guideline. Now, the MCNZ aren't on this panel, and we will be talking about regulations and legislation again in another webinar, but just to tell you that the Medical Council have revised that statement of having to be in person, and they've extended it to allow us to be prescribing in this circumstance. But Sam King, I wonder whether you can talk to us a little bit about safety as clinical practitioners.
Yeah, sure. I think that most medical doctors anyway haven't had the opportunity to look at the Medical Council website, but they do have a really good statement on telehealth and one on good prescribing. The thing about prescribing is it comes down to your clinical decision as to whether you believe you have enough information, however you have arrived at that information, whether it be in person or by phone or by other platforms, whether you've got enough in order to prescribe safely. And as all prescribers will be aware, that if you sign that prescription or you send that e-prescription off, you are responsible for it. And the Medical Council do hold us to the same standard, however we consult with our patients. And I think that's important to know. So in order to be able to prescribe safely, I do recommend you have a look at those statements and work accordingly. And as you've said, Ruth, the Medical Council have changed it. Previously, they have said that if you are prescribing a particular medication for the first time, it must be with an in-person consultation, and they have changed that. The main thing for you is to use clinical judgment. And I know that for a lot of us, we would much prefer to have a tick box where we say, oh, if we've ticked all the boxes, then we can do it safely. Most of us, of course, are risk averse. Unfortunately, there is no tick box. And you do need to use your clinical judgment, which all of us use every single day that we work. So it's not something, I don't think, that is beyond what any of us can do. I think it just bears you just need to think about it.
I think that's great advice. John, from a secondary care perspective, what would you have to add on that?
So, yeah, look, it's, I mean, we've kind of been forced a bit into this. There's been a lot of work done on this in recent months and years, and then suddenly it's been kind of forced upon us quite quickly. So a little bit of uncertainty, and to move forward and take some of the issues that have worked really well forward into the new world. To quote Sam Mitten, no going back to what we did before. But there's a lot of issues to work through, is there not? There's some real positives about shared decision making, the legal aspects in discussions with the Health and Disability Commissioner. The code still applies, so we need to be very careful around that. But it is kind of a brave new world that was always in the background and is now thrust into us. We interact in primary and secondary care a lot It could be much more seamless. There could be better interaction. We could be side by side in the kind of the telehealth or virtual consultation spheres pre-hospital to direct people into the right places in a way that's better than Healthline perhaps can, given their limitations. So look, there's a lot of really interesting things being raised around legal aspects, equity, really important, safety, but our volume through emergency departments has shrunk to, it's gone down to between 90 and 50% across New Zealand and Australia, but it's sort of building back up again, and there'll be some unmet healthcare need in amongst that. But we're kind of, and general practice might be the same, there's more of the stuff that we really need to do, but we're a little bit concerned about some of the unmet healthcare need, both acute and chronic. So look, it's really, really interesting to see how this has been thrust upon us, how we'll need to take some of the very good things that work out of this, work through some of the problems and issues, and move forward using this as a new platform.
Thanks, John. You're presenting from outer space there. Actually, there's a few questions up about people's backgrounds, which we probably won't cover now, but I think it can also affect the audio quality. So you may need to remove your virtual background so that we can hear you better. Hey, Sam, Mitten, I'm interested in your perspective on clinician safety, because I mean, again, you've chosen, I think, very wisely to move very fast in general practice with us, and we thank you for that. But I imagine that you've been fielding quite a lot of calls from people going, oh, you know, how do I make myself safe?
Yeah, so when we first suggested moving to telehealth, we talked to Medical Council and the HDC and had them on a webinar ourselves just to get people feeling a bit more comfortable about it. And the HDC said that we're still responsible whatever context we are in. So in the COVID-19 world, in the telehealth virtual world, whatever context we're using, we still are accountable in some way, but the context will be taken into account when you're dealing with stuff. That doesn't mean that you can behave in a different way that makes people unsafe. It means that you need to be, in some ways, I find that I'm probably a little bit more cautious about patients than I am using a phone for or using a video consultation for, and just make sure that their conversation very clearly is recorded in my notes, and also is very clearly, I have made the follow-up and planning for what's going to happen next, so that if there is any issues that come up, then I've got obvious record of that. But also bringing people in for an in-person consultation if you are at all concerned that you haven't quite got to the bottom of what's going on, or you need to see them for some reason. And some things it's actually quite tricky for the patient to do via video or through the phone. And for sometimes I've heard a lot of practitioners saying, well, actually, I just love to see people's face to face. And even the Prime Minister said, you know, I miss people. And I think we all miss people. But this is an enormous opportunity for us to be able to provide access for people who can't physically come in. But I think we need to also remember that people do sometimes need to physically come in, and we should be valuing that and supporting that for our patients.
Yeah, I think patient choice is really important here, and there's a few people commenting on that in the thread. There's also a few, you know, on that ongoing sort of, how do you decide if something is safe in terms of security and privacy, and there are, of course, Ministry of Health guidelines specific to DHBs, which is slightly different from what we're practicing in private practice. So there's quite a big spectrum out there of requirements. And like I say, we are going to talk more about regulatory and legislative things in another webinar. But Sam, I don't know, did you want to touch briefly on patient privacy and security?
Yes, thanks, Ruth. Obviously, privacy is a big issue, and we're all bound by the Health Information Privacy Code. So the main thing I think you need to think about is informed consent. So patients need to be aware, one, of the limits of however you're going to conduct your consultation, the limits of a telephone conversation are very different from the limits of a video consultation versus an in-person. And I think it's important to lay that out with your patients. So it helps them feel secure to know, oh, there are limits, that it's not just like coming into the surgery. And also they'll want to know that their information is held securely and that the platform you're using is secure, that there will be, if you're going to record, and I would imagine that most doctors won't be recording their consultations, but if you do, that needs to be held in the patient file and held securely as well. And so it's worth having that conversation. I don't think it'll take long. Something you could do, which would save you some time, is to print all the information out, and when a patient books for a consultation, you could email it to them so they can read that before they come and see you for that appointment. And that just saves you time, unless you know that they have the information. And then the patient can decide, yes, it's for me, no, I'm not comfortable with that. I think there are certain procedures that you can go through to ensure that that the patient's privacy is protected. For example, ensuring that if they're not your regular patient, and I'm sure a lot of people are, a lot of clinicians are having first consultations remotely, is to ensure that the identity of the person that you're consulting with, and however you need to satisfy yourself. And if you consider the Privacy Commission, it's all about satisfying yourself, and whatever that means for you. So that might be a birth certificate or a passport or something along those lines if you've not met that person before. It's also considering, where are they? Who else is in the room? You know, they could have 5 people in the room with them and you will not know, and if they're off camera, for example. So it's important to ask them who's in the room with you. Am I on speakerphone? And then that way both of you are aware and of, you know, what's what going forward. I think too that if you have somebody else in the room, a med student or another healthcare worker or whoever that might be, the patient needs to be aware of that as well. And that means that they can make a decision regarding privacy. So those are probably some just initial thoughts, but if you get a good process together, then, and you can just follow it in the same way that we all follow particular processes as we consult. You just have one for privacy, you have one for informed consent, and I think that provides safety for both patient and clinician.
I think that also highlights that we're all different, aren't we, in terms of our risk averseness. So what may satisfy one clinician may not satisfy another. Right. So it is a spectrum, isn't it? Yeah. Yes. At this point, I'm going to
just interrupt for a second.
Yeah, go, Stan, please.
Yeah, just it was just the recording thing. The recording I would do would be in my notes, not recording. But the other thing is, I always write that this is a phone consultation, so I actually document that the consultation is via phone, so that I know that that's going to be a different consultation from what I would have done as a normal one. So I just record how that consultation's happened.
Very good point. Thank you for that. I think the next couple of things we're going to look at is there's a few questions coming up about finances and reimbursement, and also dealing with the need to examine patients. So Becky, I know that this is a big thing for our allied health members out there. So why don't you tell us a little bit about what's what's with that, the need to physically examine patients?
Yeah, what is with that? Good question. It's really interesting, isn't it, that the subtleties of the physiology of the body and how people interact are incredibly important to our ability to assess somebody comprehensively. And so when that's suddenly removed, and as Sam mentioned, and I think Janine mentioned earlier, that you get so much richness of detail from an observational assessment. And when that's removed, it's incredibly challenging. But actually, I have been blown away by the number of creative methods that our allied health colleagues and around the country have conducted and have implemented over the last few weeks. So We've started to do things around providing videos and links to videos to demonstrate things. We've talked, people have got a lot more descriptive in their language. They started to discover how much in-depth explanation they need to provide when they can't do that hands-on manipulation or the hands-on movement to demonstrate something. They're looking at ways of how can they get a mother and baby to be videoed feeding, and then send that video in, because it's incredibly challenging to be on a video call and have someone and position it correctly to have that kind of feedback and interaction. So there's a lot of problem solving going on in the moment to explore methods of being able to conduct procedures and processes that previously were done in a physical way that now can't be. So it's been really interesting, and there's been a lot of sharing. So for the Allied Health Informatics group, we have a fantastic platform on our Yammer site where there's been a lot of sharing. We've done a number of national webinars across the occupational therapy and physiotherapy community, and I know that speech therapy, dietitians, social work are all exploring how do they manage this. And you know, alongside the physiological side is mental health as well, and trying to gauge with that, and trying to, if you can't be in person with someone, how can you convey that same intentional momentum through a video call?
Yeah, no, look, I think that's a really good point, Rebecca, because there is just, yeah, I remember my husband going to a physiotherapist and being given these sort of stick figures and this really old handout, which was just really not particularly helpful. But nowadays you can be sent a link to a video, which is far more useful, and gave him much better sort of feedback about what he should be doing for those exercises. So yeah, I think it's really exciting, the opportunities using telehealth in this way, and Allied Health are really leading the way in this. I've seen some physiotherapists do really amazing programs online where you can actually have a tailored, individualized program for your patient or client, and in general practice we haven't really caught up with that at all in terms of thinking about the common things we see around back pain or neck pain or things like that, where you can make sure you've screened for the red flags and all those key things, but then giving that good advice afterwards. So yeah, no, I think there's huge opportunities in there, but I'd love to see us do this collectively, and that's part of why I'm so passionate around some of the stuff we've done with Health Navigator, because as individual clinicians we can't begin to do all of this really well for all the different scenarios or conditions we'll see. So combining our efforts, sharing those things we've learned or those great resources would make a huge difference to really propelling this forward.
And Amiel, from your nursing perspective, and I know that you've got a different sort of experience from your digital literacy work as well. What are your thoughts about physical examinations?
Yeah, it does. It's that whole, it's a shift in worldviews towards physical examinations from both a GP, nurse, allied health perspective, because touch is a really important element in nursing, and being able to touch a person has both a healing element as well as an element of the consumer knowing that there is some type of intervention or some type of healing that's going on with them, and that's removed with our with telehealth. But it just means that there's a shift towards looking at other ways that we can help with this new adoption, because yeah, it's a whole new shift. A whole new shift of understanding of physical examination, not only for the health professional, but also for the consumer, because consumers are so used to being touched and having a blood pressure taken, having some type of intervention, that it's now missing. And so how are we going to replace that for our consumers who feel the need to have to be touched or, you know, have a type of intervention for them? So yeah, it is definitely going to take time, and it's probably a good thing that our health professionals are providing videos in place of what's now missing with that physical contact with your health professional.
Becky?
Yeah, just a very brief moment on just trying to, I think, cover the fact that as we as we look ahead with this concept of we've plunged the health providers and our consumer and our population into this non-contact and telehealth perspective, and what the beauty of that is identifying the opportunities of actually where is this sustainable and where is it not sustainable. But then we need to ask our consumer population of what they want. So actually it's this balancing act between actually how does the provider determine what is required on an in-person situation. You know, there's been a comment here from a podiatrist, very rightly so, says that the majority of his contacts potentially is required to be in person. But there are opportunities also to explore what doesn't need to be done in person and how can we make efficiencies and also benefit our consumers that way. But we need to listen to those consumers, so that's that balancing act.
Thanks, Vicky.
Yeah.
John?
Yeah, I reckon that's really important.
Sorry, Amiel.
No, sorry. Yeah, I'm just, yeah.
Go for it, Amiel, and then we'll...
Sorry. It's just, it's really important to, like what Becky said, listening to what our consumers want and need, because whilst we assume that telehealth should replace all contact, face-to-face contact with our health professionals, it really shouldn't replace that, because we know for different demographics, our elderly, for instance, they do prefer going in person and seeing their health professional, whereas a different younger demographic, for instance, they might prefer the telehealth consultation based on their lifestyle. So definitely listening to our consumers and responding to what their needs are.
And I suspect we don't really know that very well yet, do we? Because we tend to group people together and say, oh, that person is of this age or that ethnicity, and therefore, whereas actually each one of those is an individual. Yeah. John?
So yeah, Ruth, so a couple of things to add to that. We need to make sure that if we're not doing the examination, that we don't replace that with just ordering a bunch of tests. And so oh, look, I'm not going to see the patient, I'll just order this, that and the other blood test and do that sort of elephant gun approach there, because that will result in harm and overdiagnosis and unnecessary care and treatment. But you know, it's certainly got a place. And the only other thing I wanted to say is older people quite often are relatively tech savvy and good adopters, because they need to Skype and FaceTime their mokapuna, their grandchildren. So, but I do agree, you've got to make sure it's equitable across all ages, and that some clearly won't be able to, and make sure that we're looking after rural, regional places. And equity is a really, really big issue to see across all of this. But it's surprising how the elderly have taken to some of this technology and use of social media, etc. So that was just a couple of points I wanted to make. Thank you.
Sam?
Just a quick point. I'm not sure that most clinicians, I think, have a level of discomfort about not having an in-person consultation, simply because we cannot examine. And I guess one of the things when you're thinking, do I need to see this person in the flesh, is there any critical information that you can only gain through examination? If you need that critical piece of information and by examining the patient, then I suggest that you do bring them in for an in-person consultation. And even if you're partway through a consultation and you think, okay, the patient's talked about this, I need to examine that patient, it can be arranged. I'm not sure that it needs to be an all or nothing. We do it all by remote, or we do in person. There is a mix, and I think Sam Merton, you were saying that you do that, don't you? Most would do their remote consultations in the morning and their in-person consults in the afternoon.
Yeah, and actually, it's somebody else has sort of asked, well, we need to be able to, veto the patient if they still want to have that consultation by telehealth, yet we feel that we need to do the physical examination. I guess that's tricky, isn't it? Because we consent patients for a variety of different things, and this does bring the, that consent issue, isn't it? Is this the patient's choice, and how do I document that? Amia, what do you think about consent in this space?
Yeah, definitely. There are different aspects, because we have to make sure they understand what they're consenting to, especially in the digital and the telehealth space. But I just wanted to respond to a question here that actually, you know, this level 4 has forced a lot of our Pacific population groups, our elderly especially, to adopt technology. And that's first come from knowing how to utilize mobile phones, and their motivation is definitely on that connection and relational side. And how can we translate that over to telehealth? Because yes, they're building that relationship and using mobile phones to connect with family overseas, connecting onto YouTube to maybe watch videos that their minister has uploaded. How can we then replicate that so that that same motivation is then implemented into telehealth? Because sometimes there's a disconnect between what's important within certain parts of their life, but making sure that that same importance is then translated into health so that they can reap the benefits of what telehealth can have for our population groups. But it's definitely around consent. What are they consenting to, and do they truly understand what telehealth is and what's happening during that telehealth consultation?
Yeah, I think this is a whole new topic as well, isn't it, Sam? You were going to...
Yeah, I was going to say, if a patient refuses to come in for an examination, and the healthcare worker believes that it's necessary, a competent patient is able to refuse care if they would like to do that. The main thing, as Amio was saying, was it's all about information. So I think it's important you explain to the patient how important it is, the consequences of not having that examination, what might be missed, and ensuring that they say, that's right, despite knowing all of that, I'm not going to come in, and then you document that very carefully. I think in terms of refusing in the face of what is good advice, you do need to document more carefully than perhaps you would ordinarily.
Exactly. We might just move on. We don't actually have an awful lot of time left, but what I would like to touch on before we close off is finance, because there's a few questions about finance. I might start with our GP colleagues, their thoughts on telehealth consultations and reimbursement. Janine, did you want to?
Yeah, it needs to be valued the same as a in-person consultation, and there's been debates about that it should be charged at lower rates, but it just undermines what we're trying to do. So yeah, short answer there.
Yes, I agree with Janine. It should be valued at the same. But I think as a clinician, you need to actually make the effort to make sure that you are delivering the same level of care, because it's really, I've had some conversations with people who have said, oh, I rang up the doctor, we were only allowed to do them by phone, and it took 2 minutes and they charged me the same thing. I had a patient that I didn't know who I'd rung up recently, and he just needed an annual review, and I listened and chatted to him about life in the universe and what I normally do when I start a consultation in person. And so just got to know him a bit and how his life was going. And my favourite at the minute is, how's lockdown going for you? Because that's a really good opener for most people, and you can get a conversation going, and then you can start to explore what it is that they need. So I think we need to provide the value if we expect to be paid the value. I think the other trick to it all is, how do we charge this? Because I think in a lot of practices they've found that because the patient's not going past the front desk anymore, how do you make sure that you keep on top of the income and the funding and those sorts of things? And I think in my practice, and this is only one practice, remember there's lots around who do it differently, but we have made sure that everything is billed, so the admin staff at the front desk know who we've seen and who we haven't, so that's logged on the screen. And then also, and seen, I mean by phone seen or whatever. And then we have a process where they get emailed their bill straight away, so it gets emailed that day. And our turnover into being paid is quite reasonable. The other thing we do is that we then follow up that a week later with a text, and the text is very easy for people to respond to. They'll go, oh, and it'll get paid straight away, but they won't give you an email diatribe about anything. So a text is quite a good way of getting a sort of short, sharp message to say your bill is outstanding. And then if they've got any query, they have to ring back rather than email back, because it's very easy for people to have this email discussion with you, which admin really don't want to have. And so you need to work out some systems for yourself that make it work simply and easily, but also that are very timely, so that you're not leaving bills being unpaid for weeks and weeks on end, and people forgetting and then querying it all. So if it's timely in the way you bill it, it makes people feel more like, I just had a consultation, I'm paying for it straight away.
Yeah, I think that's great advice, Sam. Did any of our other panelists have anything else to add to that? Becky?
Yeah, just a quick note. Interestingly enough, I'm not sure if people are aware, but ACC have done some great work in agreeing to reimburse therapy provision at the same rates as in person. So, you know, this is very much about content. It's very much about ensuring that you are conveying and establishing the same level of care under the best practice guidelines for the consumers that you are having contact with. And I think in relation to what this conversation is leading towards, you know, I see the perspective here that, you know, in the future, if I were to call up my GP, I'd really like to be offered, do you want to see them in person, by phone call or video? And can I choose one of those three? And then here's your appointment, and expect details around that if it's a call or video. And I think it's then that you look at how does that work out for that pay structure, and whether there are any differences, because in effect, I want that person's time. I want the GP's time for that appointment. And I'm then, as a consumer, making that choice.
Excellent, thanks for that. John, you wanted to add something?
Yeah, look, just very briefly, there needs to be a bit of a change of mindset. The public needs to realise that they need us not for our ability to put a stethoscope on their chest. I'm not wanting to completely abandon examination. It's the decision-making advice. Lawyers charge you by the 6 minutes. So there's a little bit of change of mindset. It's our expertise and advice that they're kind of paying for. And sometimes examination is just show business around the edges. So it will take a bit of a change in education of the public. And look, take the low-hanging fruit from this, the stuff, the repeat prescriptions, the annual checks, and the stuff that you can. Give them the options. All of these things have been raised as options, and it's not good for everyone and every consultation. And clearly there needs to be some face-to-face. So yeah, look, there's a lot of really good ideas that have come through from this.
Excellent. I'm hoping everybody saw the results of our poll, because that was really interesting. So we've got a large number of participants here. We've got just under 800, and we're looking at almost 50% of you who've never used telehealth. And but then when we scroll down here, we can also see that telehealth by video. So a lot of us are using telephone, but we can also see that people are obviously saying this is going to change. You know, after COVID-19, do you see telehealth as a regular tool for health delivery? 81% of us are saying yes. So these conversations that we're having today are really, really important. And I know you've got whole screeds of questions there that we're just not going to get through in an hour. We've got all of 9 minutes left, but do not be alarmed, because we will do this again. We'll pick off some topics and really drill down into them. So this is really meant as an introduction, you know, to our way forward. We will also try and theme these questions and put them up on our website as well. So I'm going to start wrapping up now, because we've got 9 minutes, but what I'd really like to know from each of our panelists is their thoughts on that most critical thing that they think when you're starting out, what you need to think of, what's something practical. So let's have a bit of a round robin of that, and we'll start with Sam King.
When you try anything new, it's often very scary, and a lot of people think about risk. Risk can be mitigated, and so if you learn about how to do it and how to do it well right from the start, I think that it'll get you going, and then with the more experience that you gain, you'll be able to do it easily, and I think it will get easier and easier over time. So I just encourage you, if you're one of those I'm not an early adopter kind of people, and I'd be in that boat, just go carefully, but go well and move forward, and I think you'll find it'll all be fine.
Excellent. I love it when you can provide some good reassurance from your medical indemnifier. Thanks, Sam. Janine?
Yeah, and there's been quite a lot of questions coming through about what platforms to use and security and all those sorts of questions, which will get answered more in future. But there's also a lot of information on the telehealth.org.nz website and on the Health Navigator website. So I'm sure Andrew will send the links to all the participants for those. And it does go into, while they're not going to recommend one platform per se, it does give you some of the pros and cons of each of the different platforms that people are asking about. But the other great source is your PHO. So they've already done a lot of the work around these different platforms and can give you a lot of support in getting started. So do make good use of your PHO teams. Yeah, and the thing with, one of the things that has surprised me with COVID is that we don't actually often have to put our stethoscope on someone's chest to assess if they've got a bad chest infection or not. There are other signs around respiratory distress, and often we end up feeling like we need to do a physical examination because the person is there as an in-person consult, and you feel like you sort of almost need to examine them, when we know that in clinical care 90% of it or about that comes from the history. So that history is really important, and you can do a lot of that by telehealth. So yeah, just encourage you, give it a go. The other thing, there's been a few questions around group visits using virtual health, using telehealth, and that's a space that I'm really interested in, because we've been starting to do shared medical appointments and group visits. So again, that's something we might better talk about in a future webinar, or you're welcome to contact me, and we may well look at setting up a group that can support each other in doing that.
Excellent. I love that offer. Sam, Mitten?
Yeah, I mean, I would just encourage everyone to take it on board, because this has huge potential to change how we deliver healthcare, and we have all been clamouring for change for a long, long time, and ways of increasing equity amongst our patients and making sure that everyone can get access to care. And if this is a way that we can actually give access without having people having to travel, wait, come at a time that's convenient for us rather than them, it would be a way better way of delivering the care that people need. And we still will need to see people in person at times, but it should be a lot more managed and a lot more planned, and so therefore is an easier process. I've had some really great successes in this last few weeks of patients who have been actually miles away, and we've still managed to do a really good job of getting all their care dealt with, even just by phone, and using the services that are around them. So it's a huge opportunity for us to really change how we deliver care and do it a lot better. And if this is the thing that changes equity, then there's no way we should be going back.
Amio?
Yeah, so thank you, everybody. And just going on from what Sam said, it's a great opportunity for everybody to be on board. Don't be afraid. And if you are, just take a chance. But there are organisations that are available for our consumers to help with digital skills. Our library is a great source for anybody who needs to increase their digital literacy skills. We've got the 2020 Trust, as well as our whānau members, but definitely also remembering that there are different scales of adoption. So whilst you might have the majority of a certain demographic on social media or utilising mobile phones, we shouldn't forget about the remaining 10% or so who are still trying to keep up with the adoption to telehealth. So just remembering those that are still trying to find their way within the space. So thank you, everybody.
Thanks, Daniel. John?
Thanks very much, Ruth. Yeah, look, many of the things have been mentioned. It's about choices for our patients, our consumers, our population. It's about managing their expectations, and so letting them know what it involves, giving them choices of the virtual, the video, the face-to-face, and it won't be one size fits all, and there'll be a mix of virtual and face-to-face. It's also about collaboration between primary and secondary care. And hasn't that been one of the things that's come out of this COVID crisis? The amount of collaboration we've had between the community, primary care, secondary care, hospitals, outpatient visits. And again, there's many of those that can go virtual as well. And then, of course, I couldn't get away without mentioning choosing wisely and rational use of our health resources, because that's about less for many, but more for some, and choosing the people that need the resources and need the face-to-face and need the care, and the worried well that perhaps don't need that over-diagnosis, over-treatment, over-testing. And the only other equity issue, of course, to remember is our very, very rural people that can't get into the major metropolitan centres, and some form of virtual consultation is going to be best for them. So, look, I'm really excited about the way forward. We need to talk more about this. There's been a lot of questions coming through, and certainly we're going to move forward into a new normal.
Becky, now I've left you to last, partially because I also want you partly because Allied Health always leads the way, and I'm just reversing the order a little bit, but also because I just want you to finish off telling us about HINS as well, and next week's webinar maybe. So tell us your vital points on telehealth, and then finish up and tell us about HINS.
Okay, thank you, Ruth. So yes, I mean, John really got it in a nutshell, which for me, I totally agree with. It's about choice, and that starts with contacting your consumer, however that may be, to have a conversation with them about the modes available. And it's about offering those modes. It's about switching in the middle of that contact to a different mode if that's their choice. Because at the end of the day, if we just impose a single choice on them and come away and we think, have we met their needs? If they tell us, then we can come away assured that we have met their needs and that we have done it in a way that they have desired, and actually facilitated it in a way that has met their expectations. So I think that's absolutely key, that when you are contacting them either that first time or only time, that you're still giving them a choice of how they want to conduct that contact and that telehealth activity. The other thing I wanted to say was also about the fact that we need to drive industry development to ensure that the platforms that we have had skimming down through those questions of which platform is best, I believe that the prevalence use of platforms that have taken off are because they are user experience friendly. And because it's either a one-click touch for access in terms of a video platform, or because it's a pickup of the phone. But we need to actually pursue and drive our industry partners to ensure that they're developing platforms that are competitive at the point of simplicity, because we can provide ourselves with education, we can provide ourselves with digital literacy, but we also need to make sure it's incredibly simple for our consumers to engage with. And so segueing from that into HINS's next week's webinar, we have got a webinar on Thursday lunchtime, 12:30 to 1:30, and we have got the amazing Richard Corbridge joining us from the UK and sharing insights over the recent weeks from the UK. Now, he is a health technology innovator, and I think we've got quite a bit to learn there, and I think we've also got hopefully some resonance with the issues that we've also been tackling, but it'll be great to sort of hear about it from a slightly different perspective, and perhaps there are some really key learnings that we can take forward. So next Thursday, 12:30 to, no, I got the time wrong. Next Thursday, 5:30 to 6:30, because otherwise he's going to get up early. We're going to have it with a glass of wine. So apologies for that. It's 5:30 to 6:30, and you can find the registration details on the HINS website, and that's www.hins.org.nz.
Thanks, Becky. And I think HINS is dealing with a very broad digital platform, patient portals, those sort of things, and we're specifically dealing with telehealth and the barriers for telehealth, which overlap somewhat, but HINS is a great reference site. So look, I'm aware that we've actually run over time by a couple of minutes, and we're losing some participants. So the first thing I'd like to say is our amazing Telehealth leadership group team backing us all up, Andrew Pankhurst and Pat Kerr, who've put this together. Thank you so much, you two. You can't see them for our audience out there, but they are just superb. And you know, it's thanks to them that our website looks so wonderful and there's so much information out there. Thank you so much to our panelists who've given their time today, and I'm hoping that they will all come back and talk to us some more. We will definitely be doing more webinars. We were sort of gauging enthusiasm both from ourselves, our presenters, and our audience, but it sounds from the comments that we're getting that we really need to do some more of these and drill down a bit more. So yes, we will be doing more. So thank you, panelists, and thank you for all those attendees. The chat's been fantastic. It's been really great and gives us a bit of heart, I think, as well. And we'll be taking all of those comments on board for our next lot of excellent. All right, ka kite anō.